My name is Eunjung Park. I am a clinical professor for the Department of Coloproctology. Today, we're going to talk about our pathway of developing the multi-layer anti-cancer rectal suppository for use in patients with progressive mid-low rectal cancer. This is a transitional study conducted in company with Professor Seung-hyuk Paik of the Department of Coloproctology and Professor Sung-ju Hwang of the Department of Pharmacology, Yonsei University College of Pharmacy. The subject of this study was patent registered last year. Now, let me get things started by talking about the concept and therapeutic efficacy of the investigational product. As far as middle and low rectal cancer goes, there are a variety of treatment strategies available. When we can locate the tumor so near anal margin as to be touchable within 10 centimeters off the anus, we call such mid-low rectal cancer as stage 2, 3 in clinical terms. When accompanying lymph node metastasis or tissue infiltration severer than hemorrhoid, we call such rectal cancer as locally advanced rectal cancer, for which the standard therapy involves preoperative chemoradiotherapy without applying surgical treatment right away. Such radiotherapy involves 2 or 3 times of FL chemotherapies using radiosensitive 5-FU, standing for 5-fluorouracil, resulting in regression of tumors over 6-week to 8-week withdrawal period afterwards. Followed by that is the eventual surgical procedure and anti-cancer treatments depending on the cancer stage after the surgical procedure. The standard treatment method of rectal cancer is total mesorectal excision, TME, which takes advantage of preoperative chemoradiotherapy that allows surgical treatment to go transanal, not to mention better prognosis and improved survival rate. Working such treatment through the rectum, vessel, and lymph node near anal margin, we've thought there might be a better, more convenient, more efficacious pharmaceutical solution that regionally works right on target against the tumor without any needs for combined anti-cancer treatment and radiotherapy. In this rectum, the mid-low rectal cancer tumor is located, like I said, near anal margin and touchable within 10 centimeters off the anus. This means that the tumor is not in the abdominal region, but an external peritoneal space where radiation reaches. When we actually touch this part in the course of surgery, it's even closer. Taking into account the structures of blood vessel and lymph node, vessels and lymph nodes branched off iliac vessels feature good blood supply, good absorption in the lymphatic system, making the investigational product even more efficacious regionally at the tumor. There are pros and cons of intravenous injection and rectal administration. The greatest benefit of intravenous injection is that active components access directly via blood vessel for rapid onset of action. However, intravenous injection requires cannula, and its rapid onset of action rather makes controlled release quite difficult to take place, rendering injection of active component less sustainable. So, when we take to the rectal route, it is possible to see portal circulation, making it quite reasonable to be used in patients with chemotherapy-derived liver function impairment or any other liver diseases, not to mention the ability to intestinal enzyme degradation. Despite the likelihood of rectal agitation due to direct skin contact, rectal administration takes advantage in that it takes direct aim on the tumor. Next, we may think about the limitations of the conventional rectal cancer surgeries and preoperative chemoradiotherapy when it comes to combined use of radiation and chemotherapy to regress tumors. As to someone, the intravenous systemic chemoradiotherapy is still questionable in terms of its adequacy in regional treatment of rectal cancer. In the academia, some people say that, if super advanced, systemic chemoradiotherapy can be effective in treating regional rectal cancer. However, we still think that combined use is more viable for locally, regionally expressed tumors. Next, we're going to talk about monotherapy. Considering that, in the clinical settings, we often use 5-FU combined with Xeloda, which is oral capecitabine, for what is called FOLFOX chemotherapy in advanced stage rectal cancer and colorectal cancer. About using 5-FU combined with oxaliplatin for the FOLFOX chemotherapy, we thought that it would be even more efficacious if we can go with multi-layer therapy, which is what the investigational product is for. There are some previous studies worth being referred to regarding anti-cancer rectal suppository. One of these studies took place in Japan. This study regards a 5-FU-based rectal suppository and was brought into phase 2. As you can see, the investigational product of this study was quite viable in that it had low toxicity and increased survival rate, and the investigational product was absorbed way much better when administered rectally, compared to the intravenous injection. In light of the possibility of 5-FU-based rectal suppository, we've registered a patent of FOLFOX chemotherapy in the form of rectal suppository. In our treatment model, it starts with combined administration of 5-FU and oxaliplatin, followed by constant administration of 5-FU along with FOLFOX chemotherapy over 3 days. Quite similarly, for FL chemotherapy model, we start things off by using leucovorin, followed by 5-FU, sustainably repeating the therapy over 2 days. In our novel designs, these therapeutic mechanisms are realized in the form of rectal suppository. Doing so, we would develop multi-layer anti-cancer rectal suppository, where the outermost layer is oxaliplatin plus leucovorin, followed by long-acting 5-FU for controlled, sustainable release. Thanks to the dose form of this suppository, the investigational product can be used in patients where oral administration is not a viable option, like pediatric cancer patients. Considering that the low rectal tumors are located near the anus and touchable, it is expected rectal suppository will take dramatic effect thanks to its immediate release of active components. The investigational multi-layer anti-cancer suppository is of the novel design where the layers are affinitive to rectal mucosa for intensive release of oxaliplatin, followed by long-acting sustainable release of 5-FU. Up until devising the novel design, we've come up with several other designs such as solid rectal suppository and liquid suppository that thermosensitively transitions into gel. Within the novel design, the solid-type suppository for controlled release of active components, we've also come up with several designs, first of which is the original design where active components are multi-layered and released one after another. The other is of top-bottom multi-layer, where bottom layer releases the active component at a faster pace and the top layer component is released sustainably. In our model of this top-bottom layer suppository, we've designed 5-FU on the top combined with a polymer for sustainable release, and oxaliplatin at the bottom for faster oxaliplatin release. Upon fast release, once this top-bottom multi-layer suppository is in the rectal membrane, oxaliplatin works at rectal mucosa, while the polymer-combined 5-FU is released sustainably for extensive exposure. As for this top-bottom multi-layer suppository, dissolution test is now underway. When successful, this top-bottom multi-layer suppository can be further developed into the novel form where 3 or more active components are in a single suppository. We expect indications of those complex formulations available in the market can be expanded with this novel multi-layer suppository design, not only for cancer indications, but also other indications. There exist a variety of treatment strategies for rectal cancer, and we aim to help patients treat rectal cancer in more comfortable settings with less side effects and stronger therapeutic efficacy. By developing the viable anti-cancer suppository that can be brought to use immediately in the clinical settings. We further expect that our novel suppository design also helps boost the regional radiation treatment, eventually leading to improved therapeutic efficacy in rectal cancer patients.